We'll go ahead and get started. Thank you for everybody coming back. And today's topic is really important. I know you're recording it, so for those who had other obligations, they could certainly watch it because mobility is definitely the key to success. And this is a really good topic to review on all levels, an outpatient setting, an assisted living setting, nursing setting, and so on. So before we jump into the key points for mobility, I wanted to talk about the normal aging and what happens to your body so that we understand a little bit better when we're moving and we feel those aches and pains and we can't walk as far as we used to and have difficulty with some exercising, why it's actually happening and when it happens. So let's talk a little bit about normal aging. And I have three different categories for that: joints, bone, and muscle. And I think they're equally important. And I think they all contribute to the restrictions on mobility. So joints, as we get older, normal aging, it doesn't mean you have to have been an athlete or any other reason, just normal aging, your cartilage gets disorganized. It's disordered cartilage. There's nothing you can do to prevent that from happening. It's just going to happen if it is going to happen. And the fluid in your joints are decreased. So what exactly does that mean? It means that that lubricant is lessened and the joints become stiffer and less flexible. And that certainly brings a more challenge when you're going for a longer walk or getting up in the morning, or if you even have some arthritis too. Bones. Bones, the next category. If you do fracture, and that's the big, concern is if you do fracture, there's a slower healing, and the healing is not only slower, but the quality of the bone that has regrown is not the same as when you were younger. So you have slower healing of fractures and decreased bone mass. And the importance of that is it's decreased bone mass both in males and females. And I know that we associate decreased bone mass with osteoporosis, and we associate osteoporosis with females, but that's not necessarily true. Men have osteoporosis also, so they have decreased bone mass, which means they're more vulnerable to fractures, repeated fractures, more serious fractures, and complications as a result of those fractures. Height, it's kind of a joke. I ask my patients, what's your height? How tall are you? And they say, well, when I was in the Army or the Navy, I was 5'10" or 6 feet, and now I'm 5'8". And why? Why is that? Why did they lose so much height? And the answer to that is they've decreased their height simply by shortening their trunk. So the legs didn't shorten, it's the trunk. And how does your trunk shorten? It shortens because the vertebrae have cushions. They have discs in between them. And you hear about herniated discs, ruptured discs, bulging discs, and you hear that a lot in the younger adult or middle-aged adult. But you don't hear that. You don't hear about a bulging disc or herniated disc in a 100-year-old or a 90-year-old or an 80-year-old. And the reason being is that that fluid has diminished. And so with the discs losing fluid and the discs becoming thinner, they lose height. So they can easily lose an inch, 2 inches, maybe even more. The next category for normal biology of aging, and everything we're talking about is normal aging, is the next category is muscle. As we get older, the muscle mass decreases due to loss of muscle fibers. So once again, you can, this is normal aging. There's nothing you could do to prevent it. And you could go to the gym if you're 60, 70, 80 every day all day, and that's not going to compensate for the absolute loss of muscle mass that is irreversible. Now you can maximize the muscles that are existing and remaining and use those to the best of your ability, but you can't really recruit more muscle mass. So decrease in muscle mass is due to the loss of muscle fibers, and it's more in the legs than in the arms. So that's why if we take a 20-year-old who has pretty strong legs and pretty strong arms, like if we took Arnold Schwarzenegger, who was an amazing athlete, and we look at his legs when he was younger and we look at his legs now, you would see marked differences, but those muscle bundles get infiltrated with fat. So his legs will look lesser, defined, and you could tell there's less mass there, but it could be confusing because there's infiltration of fat into the muscle bundles. And why is that important? That's important because if an individual who's younger and works out, and younger is 20, 30, 40, and works out, and their body in their mind looks relatively the same size, and they go to lift weights and they don't have that muscle mass, and they keep saying no, no pain, no gain, no pain, no gain, and they lift weights that far exceed what their body is able to do, then they'll rep the muscle via the biceps tendon, and they'll have what's called a Popeye muscle, which I believe I've mentioned in previous lectures with this group. And it's a shortened muscle, and then they have to have surgery to repair that. So it's very important for not only the older adult, but the younger adult to recognize their limits. So muscle changes, as I say, more in the legs than in the arms, are seen as early as 20s for the men and 40s for the women. So 20-year-olds don't really consider themselves old, but their muscle mass is absolutely altered. So if you think it's starting in the 20s, imagine what happens when you're in the 80s. I'm not here to give you all bad news. There's definitely ways we can maximize what we have left, but I wanted to kind of give you the foundation of what's going on in your body so that you don't blame yourself and you don't say, wait a minute, I'm not the way I used to be when I was younger. I must have done this, I must have done that. No, it's truly normal biology of aging. Lastly, is the last bullet point I want to share with you before we talk about mobility is the decrease in basal metabolic rate. It's very predictable. So the decrease is 4% per decade after 20. Once again, that young 20. So decrease 4% per decade after the age of 20. So when you say I'm getting older, I'm slowing down, it's not just something to say, it's true. Your body is slowing down. So in order to get that energy, that desire, that motivation to run, and keep the fat off and keep the muscle and keep your body mass index to the level you want it, the older you get, the more of a challenge it is because you don't have that high basal metabolic rate that you did prior to the age of 20.
Susan, what is basic metabolic rate?
It's
in layman's terms.
Thank you for asking that, Larry. It's basically how your body takes in the food, breaks it down, and produces energy. So children or athletes can eat a large amount of food and they burn it off really quick because they have a high, which is the basal metabolic rate. So their body is revved up and it can consume that caloric intake and create energy so that athlete can run that extra mile or that child can play that extra soccer game. But after 20, it starts to slow down. So when you're, and that's the reason why the person who's 20 years old, you fast forward them to 50, 60, 70, they tend to gain weight. When you get into advanced age, that you can see weight loss, but it's not because you're burning off the food that you're consuming quicker. It's probably because you're consuming less food, either because you've lost your sense of smell, taste, or lack of socialization, or a whole host of medical conditions that could be consuming those calories for you, such as cancer and infections and so on. So basal metabolic rate is the speed at which your body takes that food and creates energy, and when it's slowed down, that's when you start to gain the weight and preserve more fat.
Thank you.
So, oh, you're welcome, anytime. So let's go on to, and I wanted to do that framework so that you understand why your body is reacting the way it is. So the topic today is mobility. And when I think of mobility, I think of two things. I think of what are the consequences of a person who's not moving, and what are the consequences of a person who does move. And now you say, what do you mean consequences of a person who does move? What are the risks? What happens if we take an older adult and they are walking, or they are running, or they're skiing, or they're doing other types of activities? And we're going to go through that. So with mobility, let's talk about the immobility first. Because of the slowing down of our body, that basic metabolic rate that I'm referring to, we don't have that burst of energy that a 5-year-old has. We're slower, we're more sluggish, and we tend to move less. Okay, because of the disordered cartilage and the loss of fluid, and our bones now aching more, it's a disincentive to create pain, and so we avoid what's causing that pain, and so we move less. When hospitalized, the philosophy of those who were born in the 1920s and 30s was, when you're sick, you go to bed and you rest. And you need to give your body the time to recuperate, and rest is the best medicine. And that is true. However, the statement of, if you don't use it, you lose it, is even more true. And so when we have an older adult who is hospitalized, whether it's because of an infection like a pneumonia, or whether it's because of an elective surgery, immediately we have physical therapy come by and assess that individual and see what kind of exercise can they perform while hospitalized. And the reason for that is, if you don't get that person moving within 24 hours, they start the deconditioning process. So 24 hours is the risk factor. So if you're not moving for 24 hours, your body starts to have the muscles decondition. And if you stay longer and longer in the bed and you decondition more and more, you're getting weaker and weaker. So deconditioning simply means that the muscles lose the strength that they had the day before. You say, how can it happen so quickly? It can. And it not only can happen in an older adult, it can happen in a younger adult. So we have children who had whatever kind of injury they've had, would it be a broken bone or an infection, and they have to be bedbound for a period of time. They have a challenge in trying to run with the other kids. It takes them a while to get back to being their old self. They can do it, but they don't bounce back immediately. The older adult is, with all the comorbidities, is at such a greater risk of not getting back. So when I interview somebody in the hospital and I say, okay, you're here for pneumonia, when did you start feeling sick? If they're not exactly sure, I start asking about events. Were you sick during Passover? Were you sick during Easter? Were you sick during Christmas, or whatever the holiday is? And that triggers their mind. And it's so important because I usually say, what was your physical state, your physical ability 2 weeks prior to the start of the illness that brought you into the hospital? So if you were having the sniffles and you thought it was just a cold, or if you just didn't feel right, I want to know how you were 2 weeks prior to that. That gives me a baseline. So if you say, okay, Dr. Varano, last month I ran a marathon and now I can barely move. The goal is to get physical therapy in there immediately and get you to that point where you can not only walk, but you can run. Okay. If we lower our expectations and just say, well, a month ago you ran a marathon, but today clearly you're not in that shape. If the person didn't have a stroke, if the person didn't have a physical insult that would prohibit them from running, then we have to do everything in our power to get them back to that baseline. And the reason being is if we don't, chances are they will never get back to that baseline. And that's a stepwise decline that we tend to see a lot. So we have an older adult who says, I'm just exaggerating, I ran a marathon, okay? And now they come in and we allow them to rest. We don't give them the physical therapy that they should get. We're not aggressive. They get discharged to home. They're still going to baby themselves and they will never recuperate. But they do brisk walking. Then they're hospitalized for something else and we don't get them back to that baseline. And then it's a stepwise decline and decline and decline. And before you know it, fast forward it, 6 months, a year, 2 years, they're not walking at all. So you don't want that because that's something you have control over. That's something we have control over. So as long as we know what your baseline is and there's no medical reason to create a physical limitation, then we should be extremely aggressive in recruiting whatever muscle fibers we have remaining, in toning up the muscle fibers that are now dormant, waking them up, stimulating them to get strong again, okay? So if you're not moving and you're immobile, you can certainly spiral down to the point where you're going to need an assisted device, and an assisted device could be a walker, a wheelchair, a whole host of other things, because you can't get up on your own, like those chairs that sit you up because you can't stand up on your own. So it actually lifts up your buttocks so that you're more in a straight position to get from a chair, a big chair, an armchair, to a standing position. So there's a lot of devices out there that can help you. You don't want those devices if you 2 weeks prior to the start of the injury, you were completely independent. Okay, and I give the example of the marathon runner as an extreme case, but it's to illustrate that those who are in their prime time, if they don't keep up with it, can certainly slip. Now, with that being said, I want to state at this point that the younger adult, the 20, 30-year-old or 18-year-old who goes to the gym and works out, I think that's great. I think that, physical exercise and taking care of your body is very healthy. It's I applaud them for doing that, but quite frankly, it's cosmetic. So an 18-year-old, unless they have a genetic predisposition, an 18-year-old should not have coronary artery disease. An 18-year-old should not have high sugar, and unless they have, once again, type 1 diabetes or they're in the minority of coronary artery disease with genetic predispositions. But for the most part, a teenager should have a clean bill of health. And this exercise is great because it's a foundation for them to continue that healthy lifestyle for the rest of their life. But it's truly, in my opinion, more cosmetic than medically necessary. And it's a good habit to start, but I wouldn't say it's medically necessary. For my older adults, I would say exercise is medically necessary. I don't think it's cosmetic at all. I'm not looking for my 80-year-old to have a six-pack. I'm not looking for my 70-year-old to show off their defined muscles. That's not my goal. My goal, or wear a bikini or anything like that. That is not my goal. That the teenagers are doing it. They're doing it to look good. My goal for the older adult is the stronger you are, the more flexible you are, the better balanced you are, the greater chances that you will prevent a fall from happening. You will prevent yourself from ending up in a long-term care facility, in a assisted device situation where you need to have that walker or a cane or a wheelchair. So we're going to talk a little bit more about that in detail, but I wanted to stress that exercise for the older adult is basically a prescription that I give out that I feel is just as important as taking your glaucoma medications or your high blood pressure medications. Because if you do have an insult that puts you in the hospital, so let's say you get hit by a car, you go into the hospital, you have a couple broken bones, you're in bed, you really can't do much because you have broken bones. If you were admitted into the hospital and you're physically at your peak state and you've been insulted because you got hit by a car, the chances of you rehabbing are so much better than the same adult who was a couch potato and did no exercise at all. So your pre-hospital physical state is a direct predictor of how you are going to recuperate and how you are going to rehabilitate, hopefully back to your baseline. Okay, so going back to immobility. Immobility has a tremendous amount of consequences. We talked about the deconditioning, which means you lose that muscle mass and you may never get it back. You lose that pre-morbid baseline that you may never get back. Okay, that's true. But with deconditioning, with immobility rather, you can certainly have constipation. So when we have people who are admitted into the hospital and I have physical therapy come by and they've taken Mr. Jones, who's been in bed for a day or 2 days, and they get him up to walk, before you know it, he's like, I got to have a bowel movement. I got to go to the bathroom. So talk to any physical therapist and they'll confirm that if you take somebody who's been resting in bed, not only is their body resting, but their bowels are resting. So they're on a bowel rest. And when they get up and the bowels get stimulated, then they propulse that food out and you feel that urge to have a bowel movement, okay? So moving helps with constipation, no doubt. If you don't move and you get constipated, there's a lot of poor outcomes as a result of that, stuff you don't even think about. So let's say you're not moving, you're in bed, you become constipated, okay? Then you have to have a bowel movement, you're going to be straining. Repeated straining will absolutely cause hemorrhoids. Hemorrhoids can cause pain because they could be itchy. They could be, they're protruding. If they're external hemorrhoids, if they're internal hemorrhoids, they cause a whole host of other problems. But the external hemorrhoids can be swollen. It can be painful, it can be itchy, they can bleed, they can leak and go into your stool. And if you end up having a guaiac test for whatever it is, they can turn out positive. And you could have, a false positive that your stool has blood in it when it's not your stool, it's the hemorrhoids. So, but usually we see red blood around the stool. But if you're doing your own guaiac, if you're taking your own stool and putting it on a card, then the physician doesn't see that that's fresh blood around it. And you might not know. So you can have an artificially false positive stool in your blood when it's not. It's blood around your stool because of the hemorrhoids. Then straining. You do not want to strain when you're older. You do not want to strain when you're older because, as I mentioned earlier, the vertebrae are thinner. And if they're thinner and you're on the toilet bowl and you're straining, what you're doing is you're doing this Valsalva maneuver where you're pushing down, you're taking deep breaths and you're pushing and you're straining and you're straining. And what you can do is fracture your vertebrae. So we see that with older adults who strain having a bowel movement. We see that with older adults who are pulling up a window and they can't get it because it's stuck. So they try to jam it up and then they have a fracture of their vertebrae. So you definitely don't want to be straining with your bowel movements because of the hemorrhoids and because of the spontaneous vertebral fracture, okay? If you're not moving, then not only are you not moving and your bowels get slowed down, but your lungs are in a cage. Your cage is your rib cage, right? So when you're sitting forward or when you're sitting, you're pushing up your diaphragm and you're decreasing the size of the cage. If you ever look at opera singers, they have a barrel chest. If you ever see certain, they call them blue bloaters, or people who have lung disease, COPD and whatnot, they have a big chest. Why do opera singers have a big chest? Because they take such deep breaths in and blow it out. They have to hold the note. They have to really give it them all. And when you look at opera singers, they're not slouched forward. Their chest is out. They're standing straight. They look like they're in the army. They're such good posture, okay? Because they're maximizing the capacity of the lungs. When you're not moving and you're sitting, you're minimizing the capacity of the lungs. You're compressing the lungs. So your shoulders are slouched forward. Your head is probably moving forward, and your rib cage is not in the position or the posture like the opera singer. Okay. So when you're immobile, that's just your posture. But if you get up and you take a deep breath and you take a deep inspiratory, expiratory breath, you're going to start coughing because you have all these foreign particles that got into your lungs because you were just sitting there and could be creating a pneumonia. So believe it or not, if you're moving and you're forced to take deep inspiratory, expiratory breaths, you can decrease your chances of a pneumonia or any other pulmonary infection because you're forcing air in and out And the cilia, or the little hairs, are going to see these foreign particles and force you to cough. And coughing is good. Coughing is healthy. It's saying there's something here that doesn't belong here. And it forces you to expel it, and that decreases your chance of getting a pneumonia. So that's a very important part. Okay. So now we're going to move on to, oh, and then one last thing, which is very important, but for those who really, really don't move, it doesn't take long at all for your skin to break down. And if your skin's going to break down, you can easily have ulcers, and they're called sacral decubiti. And the bony prominences of your skeleton, and if you don't have a lot of tissue, so if you're a skinny person and you don't have a lot of soft tissue, that bone pressed up against your skin because you're laying down so often will break down that skin. And if you have skin breakdown, then you have ulcers by your sacrum, and those are called sacral decubiti. And the problem with those are they're difficult to heal. And a nurse, a doctor, a healthcare professional can stage them for you. But if they are not treated, they can become so bad that you would have tunneling, which means you could actually put your finger through the ulcer. You could even see bone sometimes. So you definitely don't want that happening because it could take months to heal. So immobility can lead to skin breakdown, that being ulcers. Okay, so those are the bad things of not moving. Now, what are the bad things of moving and what are the good things of moving? Well, the good things of moving is it absolutely can help decrease leg swelling. So as we get older, we tend to see that there's more venous insufficiency. 70% of those who have leg swelling have venous insufficiency. And it can be caused by a sedentary lifestyle. So the treatment is very simple. It's not surgery. Yes, you can wear compression stockings. You could do that. But one of the best treatments is exercise. Getting up, walking, or doing calf pumps. All those will decrease your symptoms of chronic venous insufficiency and decrease your leg swelling. And if you don't address the lower extremity edema, that volume, that pressure can break down the skin and you can have ulcers in your lower extremities. So we tend to see those who don't treat the swelling, the edema of the lower extremities, they have weepy legs, which means the fluid is so tight that it just leaks through the skin. And so you see them with bandages on, you see them with skin breakdown, you see them with infection that's called a cellulitis. And if you're a diabetic, you certainly don't want to have all those complications. So movement, calf pumps, exercise by walking, all that helps with chronic venous insufficiency and helps with leg swelling. We already talked about increased bowel movements. Now, if you ever think about it, when you go to bed, you can wake up in the middle of the night and void. You can get rid of your urine, but it's not common that you wake up in the middle of the night and have a bowel movement. So the bowels really do rest, and the only way to get them moving is for you to physically get moving. I mean, you could take a laxative, but that's artificial. I'm saying naturally, okay? And the mental benefit of moving and running. If you ever thought about it, you see these runners and it's raining or it's snowing and they're out there and they're running and you say, how can it be? They have shin splints and they're running. What is the obsession with the running? And the running really releases hormones that makes that person feel good. So I'm not saying you have to run, but walking certainly makes you feel good, and it increases your appetite because you're burning off calories, and it loosens your tight joints, and it is a way of clearing your mind. And so there's a lot of physical benefits, mental benefits to movement. What are the risks of moving? So I said that, there's benefits and risks, but what are the risks? One of the risks is falls. So you get up from a chair, you're wobbly, you can fall. You get up in the middle of the night to go to the bathroom, you can fall. After your first fall, you're going to be scared. After your second fall, you're going to be terrified. And a lot of my older adults who've had falls, they change the way they walk. They look down versus look ahead because they want to know where their feet are. Well, you're not supposed to look straight down. You're supposed to look ahead because you might walk into something which will cause you to fall. So falls are a big risk for future falls. So what are the 4 most used fall prevention approaches? Well, one is if you know that Dr. Varano is saying you should move, you should walk, but you're afraid to fall. I'm here to tell you that there's 4 things that you should evaluate so that you do not become a victim of falls. And the first one is medication review. So you want to go through your medications, not only with your physician, but with your pharmacist. Ask about drug-drug interactions. Ask about how they're prescribed, and should you be taking them together or should you separate them? Ask them if any of them can lower your blood pressure so much that you can get dizzy when you go from sitting to standing, and you don't want that, which is called orthostatic hypotension. So review your medications. Second thing is when you go to your physician, ask them to check your blood pressure sitting and standing, especially if you're dizzy. So if you wake up in the middle of the night to go to the bathroom, but you feel a little woozy, then you should absolutely have in your by your nightstand a glass of water. Small. You could have 2 ounces, 4 ounces. It certainly doesn't have to be a big bottle. And take a couple sips and go from your bed to standing. And if you still feel woozy, sit down. Do not proceed to the bathroom. Even if you have to be incontinent in bed, it doesn't matter. If your body is telling you, I'm woozy, they're telling you, I don't have enough fluid, and the fluid is not giving my brain oxygen, and so I will fall if you don't give me fluid. So my recommendation is to have by your bedside some water and consume as much water as needed so that you have those dizzy symptoms subsided. They got to be gone before you proceed to the bathroom. Okay, because what happens is when you go to the bathroom, you're emptying out your bladder, so you're losing all that extra volume, and all that fluid shift could cause you to faint. So you want to, if you have those symptoms of getting dizzy, you definitely want to ask your doctor to check your blood pressure sitting and standing, and that's called orthostatic hypotension. That's what they're checking you for. They're checking to see if you go from sitting to standing, does your blood pressure drop? And the reason why it would drop is a couple ones. One, you have no volume, so you're dehydrated. 2, when the fluid drops when you're going from sitting to standing and the gravity pulls the fluid from your brain down to your toes, the muscles of your vasculature in your toes is not that strong. So you can't really squeeze up that fluid to your brain to get rid of that dizzy feeling. It takes too long, and you might not have that time before you faint and go on the floor. Okay, so you want to see if you do have orthostatic hypotension, and they can treat that. And then the third one is you want to be evaluated by physical therapy to see what is your gait, what is your strength, and what is your balance. So if you have a wide base gait or a scissor gait, or there's a whole bunch of different gaits that you don't even know exist, why should you know they exist, right? But a trained physical therapist will take a look at you, see how you're walking, and say, that's not a safe gait. Let me show you an alternative. Okay, especially if you're that person who fell and is now looking straight down at the ground and not forward. That's something physical therapy can help you so that you avoid any kind of further injury. Balance. Balance is critical. And if in one of the assisted livings, they have Tai Chi, they have yoga, they have any kind of balance exercise, definitely 100% sign up for it. If they don't have it, talk to the recreational therapist and say, can we get PT to do some balance exercises, or talk to the administrator or whoever you feel comfortable. But you definitely want to maximize your balance. Why is that? Because when you slip and fall, or when you trip and fall, basically both feet are not in the air at the same time. One goes up first and the other one is on the ground. So if your body is trained to have one foot on the ground and one foot in the air, when you trip, you're not going to fall because you have that ability to stand on one leg. Okay, so balance exercises really does decrease falls, and you don't want to have falls, because if you have a fall, a lot of older adults fall with their face forward, so they have facial injuries. If they fall and they break their hip, that's a huge problem because they have to have surgery, and then the rehab on that is very difficult. So you want to eliminate falling if you can by balancing yourself as much as you can. And Tai Chi, yoga, all those types of exercises and classes can help you obtain that goal. Okay. You also want to have leg strength. So as I said earlier, your legs get weaker faster than your arms. That's why you see older adults in wheelchairs and they can propel themselves with their arms. They tend to use their tippy toes if they want to move with their legs in the wheelchair. They use their tippy toes, but that is not using the proximal muscles, which are the muscles near the groin. Okay. And those muscles near the groin are the muscles when you're going from a sitting position to a standing position. Those are the muscles you use the most. So those are the muscles that you need to absolutely strengthen. And you can work with a physical therapist and get a strengthening exercise. I sent to Mark, who sent to Arrow, a packet full of exercises. I don't know, Larry, did you get to see that?
No. What is that, Susan, again? Could you repeat that?
Oh,
yes,
I
saw it. Yes. I
Okay.
thought those exercises were very good. And as a matter of fact, Aileen just got out of the hospital again, and they replicate many of the exercises that she is doing at home. And I thought they were really very good.
Perfect. So if we could share that with the group, I think that's, I think all those can address, and they're pretty safe. Okay, I just got the chat. I forwarded to everyone. Thank you so much. Fantastic. So, and then the fourth assessment for fall prevention is home safety and modification. Now, for those of you who are in assisted living, it's already done for you. That's the beauty of assisted living. They did all the legwork for you. They modified the apartment so that it's safe. You have your grab bars. You don't have your throw rugs. You're as safe as can be. But if anybody is watching who's not in an assisted living, then a home safety eval is absolutely indicated. Now, if you are in assisted living, but you're in the independent section, have home PT come in, have a physical therapist come in and take a look at it and see if there could be further modifications, because that's important. And for those who are in assisted living with all the physical modifications, I think it's worthwhile to have physical therapy come in and say, where's the bed in relation to the bathroom? Where is the recliner? How are things set up in the apartment, and can there be an easier flow so that you are having less chances of falling, okay? So movement is important. It's important to get out of bed, to exercise, to get the blood flowing mentally, physically, and for all your organ systems, as I said earlier. If you are going to move, you have to listen to your body. If it's telling you that you're dizzy, then you need to sit down, respect it, and rehydrate it. If you are fearful of falls or you've had a fall, go through those 4 fall prevention approaches: the medication review, the checking the blood pressure, the orthostatics, checking the gait strength and balance, and of course the home safety eval. So it's 3:50. I know we end at 4, and I want to be respectful of your time, because I know for the past 3 times I've gone over, and I apologize for that. So I want to be respectful for your time, and I want to leave it for 10 minutes for anybody who has any questions.
I have a question, Susan. I think a lot of your ideas are terrific,
Thank you.
but how do we do them? How do we persuade ourselves to do them, our spouses to do them, and the people in our communities to do them?
So the first one I'm going to take is the easy answer: in community. All the assisted livings, if you have a motivated physical therapist who can do balancing exercises, it really should be something that everyone can participate in. And if you have a physician that comes to your assisted livings, then they should get on board and make it like a prescription. You're taking your Lasix, you're taking your whatever medications you're taking, and you have to participate in the assisted living's balance exercise, and just make it a prescription, and they will definitely do it. So assisted living is easy because you're bringing the exercises to them. The challenging part is when you're not in an assisted living, and that's home. So for Larry, for those who are not in, or even if they're in assisted living and they're in the independent section, it has to be a habit. They have to view it as not a luxury, but a necessity. So getting up in the morning and taking a nice deep breath in and out is critical to clear out all those particles and all those viruses and bacteria that have lodged in your lower lungs. So in the morning, that is just has to be incorporated into brushing your teeth, washing your face, combing your hair, taking that deep breath in and out. It just has to be a culture change. It really does. As far as the exercise, incorporate it into your lifestyle. So rather than parking at the closest spot to the grocery store, deliberately and intentionally, not to keep your car pretty, but to keep you alive, park further away and walk in. If you have a building that has elevators, don't use the elevator. Try to use the stairs. And so little tiny steps make a huge difference in your cardiovascular response to that in your muscle strength. Because I have to tell you, Larry, you lose, if you don't use it, you lose it. And that's a saying that is so true with the older adults, and it's so hard to get back. So you want to be as primed as possible, and in case something comes your way, you just kind of laugh it in the face, you know. So once you get that balancing and strength, if you do trip, you won't fall. You know, it's just got to be the only thing I could say to you is it has to be a necessity, not a luxury.
Thank you.
You're welcome. Now, yes, I'm sorry, I saw the hand go up.
Gwen, yes,
Yes, Glenn.
I saw you discussed a list of exercises with Larry that he had. How do I get those exercises?
Yeah, they're going to, in the chat room, Kayla is going to, how are you going to distribute it to everybody?
I just emailed it out to the residents who I have their email list to, but then I also sent it to their resident services director. Gwen, are you in a community?
Yes.
Which community are you in? And I will make sure they get it to
Kingsland
you.
Walk.
Okay. Okay, perfect. I'll make sure that it's printed for you.
Thank
Okay.
you.
So yeah, once you get it, take a look at it. We meet every 2 weeks. If you have questions about it, certainly go over it with me. If you're in a community, I wouldn't do them on your own. I would ask if someone can go over it with you. It could be nursing, it could be your lifestyle coordinator, or rec physical therapist. I mean, there's a whole host of people, but I certainly wouldn't take those exercises and just do them on your own. Someone has to be there and make sure that you're using your body mechanics in the proper way, because exercises can cause injuries if done incorrectly.
Hello, I have a question. I'm in my home and I live alone. And so you're saying I should not do these alone? Is there any, what can I do alone? You said
Well, yeah, I mean, so you're home, you're alone. You could certainly, take a look at them.
okay, so
And
you will send these by email, is that correct?
Yeah,
Kayla's,
and if you put your email in the chat, I can send it to you right now as well.
Okay, well,
Or we can stay after and you can just tell me your email
Okay.
as well, and maybe I can get it that way too, if you can't find the chat.
yeah.
so for if you're home and you're alone, I don't want you to feel as if you will miss out completely. I don't want you to miss out completely. The safest exercise for you to do when you're looking at that list is do it where if you feel dizzy, you have water nearby. If I don't want you to fall, I don't want to cause any kind of injury. So look through it and see if there's any, because there's a lot of exercises there. If there's any ones that you can do seated, or if you're going to stand, you could stand in a safe environment that if you don't feel good, you could sit right down. So take a look at it, and we could certainly circle back and discuss it in 2 weeks when we're together, because in 2 weeks we are going to be doing sleep, and then 2 weeks after that urology, and that'll be different types of incontinence and urgency, and that's going to be actually very exciting because a lot of people don't want to talk about incontinence, and I think it's a quality of life issue that would be very important. And and the other reason why I'm excited about it is because I worked as I think I told you guys, I work as one of the things I do is principal investigator for clinical research, and that's why I was talking about the Pfizer vaccine the first time we met. But I just finished working on a drug for overactive bladder, and it was approved in December. It's going to be launched in 2 weeks. And the reason why I'm so excited about it is it does not cause dementia. the anticholinergic drugs for overactive bladder have been known to cause cognitive deficits. And as a geriatrician, that's very important to me. So that's a very exciting lecture that, we'll be talking about. And then after that, on May 14th, we'll be talking about memory screens and a little bit more about that. So if you don't, whoever's on the Zoom, if you don't have this sheet with all the different lectures, certainly either unmute yourself and let us know, or put it in the chat box and we'll get the list to you so that you're up to date. Also,
I don't have it. I'm new.
when you need it,
Yes.
okay.
I would like to get a list of the lectures too. I've listened to all of them, but I would like to get the list so I would be aware.
So
Donna,
why don't you just send them to everybody so that they have, the whole roster of lectures and the dates. And the reason why I think that would be helpful is because they can prepare for their future lectures, and they can certainly, since they're recorded, know the previous ones if they want to go back to them and say, what did she say? What didn't she say? And if you do rewatch the recordings and you don't understand something, or I misspoke, please don't stay confused. Write that down as a note, keep it in a notebook, and the next time we meet, we could certainly talk about it. Or Kayla, you have my email, right?
yep, I
Yeah.
do.
So you could certainly, is there a way you can give them your email if they have any questions or concerns, and then you get all the questions and concerns and send them to me? Okay.
Yep.
So if anyone here, watches the videos and you're confused, or you don't understand something, please email, and I will get that email, and we'll discuss it.
Dr. Varano, I'm pretty much dependent on a walker. I have a bad foot that I wear a big boot on. So my husband and I do walk a lot, but there's a lot of other exercises I can't do. I try to do the morning exercises, but when it comes to the leg lifts and things like that, and the rotating the leg, and then I've had 2 hip replacements in 1 hip. So some of that I have to be really careful about. So right now, I don't believe I'll ever be able to get off of the walker. So walking that's a pretty good exercise, isn't it, to get out and walk? I try to get like 3,000 or more steps a day. I know that's not a target. They want 6,000 to 10,000, but I haven't done that many.
Right. Now, it doesn't have to be walking on ground. Do you have access to a pool? Are you able to do aqua therapy?
We have access to a pool, but I don't believe it's not deep enough for me to move with my bad foot and everything. I walk on the leg bone if I don't have my boot on. It's called something like a crow foot, where it is the bones are messed up.
Right. Okay. So, I would absolutely suggest having a consultation with physical therapy, and your goal, as I mentioned, it has to be your the 2 weeks prior to the start of the illness. And if your baseline is an assisted device, that's fine. The goal is not to get worse, and the goal is to preserve you at your current independent state. And I certainly would encourage you to contact physical therapy and say, I don't want to decline. I want exercises to preserve what I have and maybe even strengthen it. I don't want to just stay where I'm at, maybe even get a little bit stronger, and put them on the spot to say, create a prescription plan for me so that I won't fall. What can we do in my current state to maximize my balance and strength? They're the professionals. They certainly can create a plan to adapt to you and your where your physical state is. I mean, we always say we meet the patient where they're at, whether it's cognitively, we meet them where they're at, or physically. So I would encourage you to do that.
Thank you.
You're welcome.
I don't think that we have the exercises at our building.
She's in the same building I am. No, we don't, Joe.
Well, I'll unmute here.
Yeah, Joe, we can hear you, or we could. I think you muted now. Do you mean the pages of exercises that she's just talking about?
Yes, that
Okay,
people seem to have, and I don't think we have them in our building.
No, we don't, Joe.
I just sent them to you in your email, Joe, and Donna, you as well. And actually, whoever put in the chat, you should have it in your email now.
Okay. We'll get started. We're moving.
And just a word of, a word of advice. Don't do them all at once. Give yourself a little break. So create a calendar, have fun with it. Just do like, one exercise a day, and, or, you can rotate through. There's so many in there, 7 days a week. You could put on your calendar which one you're doing that day. The last thing I want you to do is get hurt. And the last thing I want you to do is get discouraged. So if you set a reasonable goal and you achieve that goal, you're going to release these hormones that are going to satisfy you. You're going to get this satisfaction center in your brain. You're going to feel a sense of success, a sense of accomplishment, and the drive and desire to do more and more and more. If quite the contrary, if you do all of them and you fail, you're going to release these hormones that are one that would put you in a sadder, I'm not saying depressed, but a sense of failure and loss of ability to do what you used to do when you were younger. And it goes down an ugly road. So just go small baby steps, and Rome wasn't built in a day, and you will really be successful if you do it little at a time.
I ride an exercise bike in the morning for 25 minutes. Does that count?
It does. Do you have a little resistance on there?
Yes.
Okay, it does. Yes, it does. Absolutely. My favorite for the proximal muscles is lifting your knees up and going from sitting from a chair to standing from the chair without using your arm rests. And you don't want to push, you don't want to rock. And that's really forcing your body to fire off those muscles, because you have to get from sitting to standing. You want to get out of that chair. And if you can do that, then you can get out of a bed, you can get out of a couch, you can, if you're on the floor, you can get up from the floor. There's a lot of benefits to that muscle group. So those are my favorite. But bicycle, that's fantastic. Good for you.
Okay, I'll keep doing it then.
Yep, keep doing it. The bottom line is this. I mean, that's fantastic you're doing that, but any movement, even if you're just pumping your calves, any movement is better than no movement. Pumping your calves while you're sitting, watching TV is going to increase the blood flow. It's going to decrease the edema. Very, very important. I mean, that's what we do when we're on the plane. It's recommended to all the passengers on the plane to pump their calves so that you get the blood flowing to prevent DVTs. Well, why shouldn't you do that while you're watching TV or watching my video? Absolutely. Any movement is better than no movement.
I mean, just up and down, up and down.
Yeah.
When you say pumping your calves.
Pumping your calves is flexing your foot. So putting your foot up into the air and pointing your foot down as if you were a ballerina. So pointing your toes down and pointing your toes down to the ground, and then pointing your toes up to the ceiling. So you want your foot to be 90 degrees and down, up, down, just like you're pressing on the gas. So if you're pressing on the gas of the car, you're pointing your toes down and then up. If you do that right now when we're on the Zoom, you'll feel your calves doing something. I see Donna shaking her head.
Yeah, I'm trying.
Mine are speaking to me.
I'm sorry?
I said, mine are speaking to me.
Good. And that's what you want. You want them speaking to you. You want to, because when you're squishing that muscle, you're squishing blood. You're squishing blood, you're preventing a DVT.
Okay,
It's all good stuff. It's all good stuff.
I'll keep doing it.
Yeah, why not, right?
Thank you.
You're
Thanks.
welcome. Any other questions? No?
Thank
All
you,
right.
Susan.
Okay, I went.
I'm sorry, Larry?
No, I just said thank you. I'm leaving.
Oh, you're welcome. Thank you, everybody. If
Thank
you
you.
celebrate Easter, happy Easter, and any other holidays you're celebrating.
Okay,
Thank you, Dr. Varano. And I am sending out anyone who put their email in the chat, or if I think I had Joe and Donna's email. So I'm sending out the link to the previous, there's a playlist of previous recordings, as well as
Yes.
that flyer that we were talking about. So you guys will see those in your email. So, but if you guys, if I happen to maybe write your email down wrong, just see your resident services director, and they can get in contact with me, and I'll make sure to get you what you need.
okay,
All right. Thank you, Dr. Varano.
Have a great
All right. Bye, guys.
bye.
Bye.